is less than 30 milliliters, you can say, oh, there is a decreased urinary output. Okay, so let's refine those terminology because it's important. This can make the difference between answering the question correctly versus answering the question incorrectly. So when you see decreased urinary output, well, when it is a compensation because the patient is dehydrated or have low blood pressure. When the patient have dehydration of low blood pressure, activate the antidiuretic hormone, which orders the kidneys to decrease the urinary output. It's antidiuresis, anti-urination, yes? And this is what you see in patients with dehydration, okay, or decreased blood pressure, that you see a decreased urinary output as a compensation. Or you can see a decreased urinary output if the patient already have a renal damage, a renal failure. This is the a cause of decreased urinary output. Okay, in case of obstruction, you don't see decreased urinary output. If the obstruction is total, because it can be total obstruction, then you see zero urinary output. Zero urinary output. If the obstruction is partial, as you see in the benign prostatic hypertrophy, where there is a certain degree of obstruction, but it's not yet total. What you see is a decreased strength of the urinary stream, so of this stream of urine that comes out, strong or weak, okay, or from the urethra. So when you see an old man with benign prostatic hypertrophy, you see that the patient is peeing, but when the patient is peeing, instead of having a urinary stream that is like this, is going to be like this and with a lot of dripping, okay? So the strength, the strength and you know the stream of urine, okay, is going to be decreased. Is going to be something like this. That's why it's very famous that you know people with BPAs have the shoes are always okay spilled with urine. Okay, so trying to understand that. So the patient is urinating the same amount. It's not totally obstructed in BPA, and what they have is decreased strength of the urinary stream. If the volume of urine, strong or weak, is decreased, is because the patient is dehydrated, the patient has renal failure, yeah, or you know, or there is a total obstruction, not partial obstruction. So I hope that it helped you to understand how to approach a decreased urinary output. Look for dehydration, look for hypotension, look for high creatinine, renal failure, but not this kind of stuff. Okay, so it is interesting because it's more probable a question about decreased urinary output, oliguria. Oliguria is called oliguria, that is seen in dehydration, in hypotension, in fluid volume deficit, in hypovolemia, and in renal failure mainly. ¿De acuerdo? While in BPH, when you see a normal amount of production of urine, o sea, a normal amount of volume of urine, but it's living very weak. The string is very weak. If the obstruction is total, then is zero. The patient doesn't pee anything, but the bladder is going to be super distended. The urinary bladder is going to be full of the urine because cannot live. So those are the obstructions symptoms, yes? In this case, what we are talking about is infection of the prostate gland. It can happen in a young man, can happen in an old man, can happen in a young man. And it produces inflammation. Remember that the prostate gland, when a doctor is examining the prostate gland, okay, the doctor is going to introduce the finger in the rectum, okay, the rectum, to palpate the prostate gland, because the prostate gland is there, it can be palpated, okay, easily with the finger, just introducing the finger, okay, not too deep in the rectum with the finger of the explorer. Okay, a nurse practitioner is trained to do that. The nurse practitioner, which is a possibility for many of you in your future, can be trained to do that. And the prostate here, okay, the testicle is here, the PP is here, and the rectum is here. So this is the way of examining the prostate. So when this prostate gland is inflamed, there is a lot of rectal pain, especially when the patient has a bowel movement. The digital rectal examination is painful in the prostate. And when the patient has a fecal bolus advancing here, making poo-poo, it's going to be painful. The defecation is going to be painful. And there is a lot of pain in the rectum and in the perineal area. Perineal area is this flesh that is between the anus and the testicles in the man. No? So a lot of pain there. The urine doesn't need to have nothing special. The urine is going to be even a normal urinalysis, because what the inflammation in the prostate gland doesn't reflect in the urine. One thing is the bladder and the urethra, and other thing is the prostate that is around the urethra. It's not in intimate relation with the urethra in sharing, okay, the infection with the urethra or the bladder. So there is a normal urine. And this is what happens in prostatitis, okay? Prostatitis is a disease that can happen in young people, young men. And it could be a sexually transmitted disease like chlamydia, gonorrhea, or can be E. coli. That is also possible and requires treatment with antibiotics. So this is prostatitis. Nice to meet you. And if you have any future question of prostatitis, this question allow us to introduce the topic. The blood in the urine. When you see the urine reddish or pink, is called macroscopic hematuria. If you see the urine yellow color, you see the urine yellow, okay? But in the urinalysis, in the urinary test, they are red blood cells. They see red blood cells in the analysis, the macroscopic, then it's called microscopic hematuria. The hematuria either is coming from the kidneys, from the ureters, or from the urinary bladder. So the blood can come from the own kidneys, like in the acute glomerulonephritis, can come from the pelvis and the ureters, like in renal cancer, or in the presence of kidney stones. Kidney stone, you know what is kidney stone, no? Nephrolithiasis, yes. Or when there is cancer or inflammation in the bladder. The cystitis can produce macroscopic hematuria, cystitis, the regular cystitis that is more frequent in women. Also the cancer in the bladder. This is what is related with the hematuria, okay, the hematuria. Urethral discharge, okay, that through the opening of the urethra, there is pus coming out. This is seen in gonorrhea and chlamydia. Okay, it's called urethritis. And then the gentleman will have this urethral discharge. Okay, these are symptoms from different conditions in the UG, in the urinary and genital system, that you need to know that are basic and can be tested. Findings in superior vena cava compression syndrome. Okay, what is this? If any of you doesn't know what is this, you need to have the basic knowledge that the veins come down from the head, okay, in this direction. This is the jugular veins, and those veins are draining the blood, the return blood of the brain, of the face, of the neck, and join the veins that are coming from the upper extremities, yeah, that are the subclavian veins, no? And all these veins join and forms only one vein. That is the superior vena cava that arrives to the right atrium, right ventricle, etc. Of course, here comes the inferior vena cava. So you need to understand that here you have the head. Okay, here you have the head, the face, the neck. Here you have the arms. Sometimes there is something growing, something that is growing here. Okay, could be a tumor, could be a lymph node, something that's growing here extrinsically and start growing and start compressing the, the superior vena cava. This is not rare because there are many tumors that can grow in the chest. Of course, the most common is lung cancer because the lungs are here. No, the lungs are here. No, the lungs are here. But can be lymph nodes and lymphoma, etc., etc. When this compression occurs, your common sense say that the blood that is coming through the brain, the face, the neck, and the upper extremities are going to have problems to reach the heart. So there is going to be a traffic jam. There is going to be a backflow, okay? Here, a traffic jam, the same that happens in the expressways, okay? When there is, okay, obstruction of the flow. So there is going to be a traffic jam for the blood. And don't forget that the blood is mainly liquid. So any traffic jam of the blood produces edema, okay, edema. And that's it. This is what you need to know, okay, that occurs in the superior vena cava syndrome compression. Okay, once you refresh the, ¿cómo se llama? The symptoms, let's see if you have this question, how you can answer that. Do you have edema in the face?
Yes.
Yes. Do you have edema in the lungs, crackles in the lungs?
Yes.
Why? Because
Lo pen-
anatomically, I need to know that the blood need to arrive to the right atrium, right ventricle, pulmonary artery, and now lung. I don't know if we are good in anatomy, but the venous blood that is coming from the inferior vena cava and the superior vena cava, this blood must arrive to the right heart, right atrium, right ventricle. And then the right ventricle need to send the blood to the pulmonary artery. And the pulmonary artery will have, okay, one from here, one from here. Okay. And what is the problem? Is the right heart sending too much blood, too many blood, too much blood, a lot of blood to the lungs, or the blood is not entering and is not sent to the blood, to the lungs?
Not answering.
I'm going to repeat the question. I have a traffic jam here, an accident in the Palmetto, an accident in a turnpike called superior vena cava. The lungs, suppose that the accident is in qué sé yo, in calle 8, in calle 8, yeah, A Street. And the lungs are beyond calle 8, okay? The lungs are in Hialeah, okay? So you are going to have a lot of cars in Hialeah if you're going if going north, the obstruction in calle 8? No. There's not going to be traffic beyond the obstruction. No comprende.
Yes,
Yes,
Professor.
Seguro? Sure.
yes.
Yes,
So
Professor.
there is no reason for having crackles in the lungs. When we have crackles in the lungs, left heart failure.
Everyone knows the Florida's economy is on fire. But here in Miami,
This person that is in class,
property taxes are on the rise.
that is in class or is listening to a class, has the microphone open. and it's disturbing a lot. Okay, so you need to understand that, because it's not only helping you, to understand, okay, this question is to understand, for example, heart failure, signs and symptoms of heart failure, etc. So if the blood is not passing here, the blood is building up in the upper extremities, okay, is building up in the upper extremities, in the neck, and in the head, not in the lungs that are here, okay? So there is no reason for that. Knowing anatomy and knowing the blood flow, the flow of the blood is enough to be able to rule out this. Flat veins in the arms?
No.
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 All the contrary, is going to be engorged, are going to be distended. Confusion. Yes or not?
Yes. Yes.
Why
I'm leaning
yes?
towards yes
Yeah.
Why yes?
because of the buildup of fluid inside of the head.
Of course, there is brain edema in this condition. If the brain cannot drain, okay, to the neck and to the heart, the blood that is entering, the arterial blood is still entering in the brain. The arteries are still bringing blood, liquid blood to the brain. But the blood cannot return. The blood is obstructed from coming back. So now it's going to be the comeback. So what is happening in the brain? Liquid is building up. So you have brain edema, and then you have confusion. So yes, altered mental status, okay? Different levels of altered mental status are expected in the superior vena cava syndrome. Then neck vein distension, yes or not?
Yes.
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 Yes. Could be present in a superior vena cava syndrome. It's an etiology that I didn't mention. Could be present in a syndrome of superior vena cava syndrome. A central venous catheter, let me explain. Could be this patient, before having this syndrome, having a catheter here in the superior vena cava? Yes, the answer is yes. Very rarely, but sometimes a central catheter can produce an obstructive clot inside the superior vena cava. It's not an external, extrinsic compression like the tumors. Is intrinsic inside a growth of obstruction because thrombosis. It's very rare, but can happen. So for your information, this should be also selected because can be described, it's a possible complication of a central catheter. A thrombosis of the superior vena cava vein with a superior vena cava syndrome. This is a topic that is important because, okay, it is a syndrome that nurses need to recognize because it's frequent in oncology and also can be seen as a complication of central catheters. You feel good now after discussing this question? Are we good?
Yeah, Professor.
Yeah, that was great.
Can
Thank
we
you.
move on? Okay. Okay. A nurse is planning care for a 2-year-old hospitalized child. 2 years. Which issue will produce the most, this is a superlative, stress at this age, 2 years? Fear of pain, separation anxiety, shame and doubt, body mutilation.
I want to say C
Shame and
because
doubt.
that's
Okay.
stress. Yeah.
It is the Erickson stage of a 2 years old. Shame and doubt. Shame versus doubt. Okay. No, autonomy versus shame and doubt. Autonomy versus shame and doubt. It is the challenge at this age, but it's the most. What means this Erickson stuff of autonomy versus shame and doubt. When a boy, or a child, sorry, uh, uh, learns to walk, is moving from infant to toddlers. That is more or less, after 1 year, 2 years, until 3 years. And when they learn to walk, they develop independence. Before they couldn't walk. Well, they were trying that while crawling, okay, like crawling. But now, okay, they definitively are going to walk away the mother, the parent, yes, and it creates a sensation of autonomy, and myself, and yo, and me. I am me, okay, and you know that when they start learning me or mine, or no autonomy, yes, they realize that before they were all time attached to the mother, to the parent, okay, held, and there is not a clear separation of identities in the mind of the child between the mother, the parents, and the child. But now the child realizes the mother is here and I'm here and separated. So I am myself. So I develop my concept that I am me, I am myself. Yeah, autonomy, and it is good. We need to promote that. But sometimes circumstances, and those circumstances are very variable. But sometimes parents are too anxious, and when the child is developing their autonomy, they say, "Hey, don't touch this. Don't go there. They take care with the coco. It is her. It is caca." So everything is going to be a fear, a fear. Take care. It is risky. Don't do that, etc. And it can produce a failure in the development of the autonomy, and can produce shame and doubt. So it's the versus that can occur at this age in the development of the personality. Okay, but at the moment of a hospitalization, do you think that it is the most important, the stress? No, it is not. So I just wanted to discuss with you what is shame and doubt, which is the versus the failure of the development in the Erickson stage of autonomy versus chef and down, but this is not the most important. So any other opinion?
A.
B.
A, fear of pain. It is more commonly seen in the preschool. The preschool and the school. Preschool and school are very smart, and they know that they are going to be exposed to situations that produce pain. The toddler is more innocent, is more naive, and still doesn't know that when they are going to a hospital, probably are going to be experiencing stuff that produce pain. You see more the fear of pain in more adult children, preschool and school age, when they know that in the hospital they do stuff that produce pain. So they anticipate pain when go to the hospital, but need to be older. It is separation anxiety, the answer. Okay, separation anxiety. Separation anxiety is what is the main challenge at this age. The infant and the toddler suffer of a lot of separation anxiety, and the policy in all the pediatric areas is to allow parents or caregivers to be hospitalized together with the child. Don't separate the child from the parents. Okay, separation anxiety. The separation anxiety appears for first time around 6 to 8 months of age. Before 6 months, it's very rare to see separation anxiety. Those kids, throw their arms to anybody that pass, near them, and are in this position of lifting them and holding them, cargarlo. But then after 6 to 8 months, you notice that they start developing fear to estrange and separation anxiety. And they are like clinging from the parents all the time. and they cry when an exchange, okay, approach the end, or the separation anxiety is called that, and this persists until the preschool age, the separation anxiety. And the policy for that reason in nursing and the pediatric areas is to allow parents to hospitalize with the children, and because the trauma that produces separation anxiety, which is the most important, okay, challenge there. Okay. The nurse is reviewing the lab result for several clients. Which of the lab results indicates a client with partially compensated metabolic acidosis? Okay, so we have a patient with metabolic acidosis partially compensated. Okay, PCO2 30, hemoglobin 17, potassium 3.4, and bicarbonate 21.
Yeah, D.
Is the best option. So the only that is fitting here with metabolic acidosis is option D. In metabolic acidosis, the pH should be low. The PCO2, if there is compensation, should be low. And the bicarbonate should be also low. So if there is acidosis, the potassium increases. So it doesn't fit because it is a low potassium. Hemoglobin has nothing to do with acid-base disbalance, has to do with oxygenation. And a PCO2, okay, is low here, so it denotes it express compensation. So more than D, that is a slightly low, is the low CO2 that report that there is compensation of a metabolic acidosis, because the compensation of the metabolic acidosis is given by the CO2. So if I had to choose what is the proof that there is compensation, I choose the option A, because this CO2 is low. The normal is 35 to 45, and this is low. Why is low? Because the compensation that we observe when the pH is low in metabolic acidosis. In metabolic acidosis, the patient hyperventilates, the Kussmaul respiration, to compensate the acidosis. So the best evidence that the compensation is happening is that the CO2 is low. The fact that the bicarbonate is low is say that it's in acidosis, but they are looking for evidence of metabolic acidosis partially compensated. And the evidence of a low CO2 is the evidence that the metabolic acidosis is being compensated. So is the decreased CO2 the one that explains the compensation that occurs in metabolic acidosis? Remember that metabolic acidosis, the best example is the patient with diabetic ketoacidosis. And those patients, to compensate, hyperventilate. They have the Kussmaul respiration. Each time you hyperventilate, the CO2 is low. Okay, so you expect low pH and low bicarbonate, but the compensation is going to be a low CO2. So if you, this bicarbonate, okay, should be, okay, 22 or more, but the patient is in acidosis, but the compensation is given by the low CO2. So if they are asking metabolic acidosis compensated, you need to prefer the option A over option D, because only a low bicarbonate doesn't mean that there is compensation, while a low CO2 in this scenario, translate that there is just compensation. So I prefer to choose in my test option A than option D. And this is an example of those questions that we see in the Nclex, that you are left with two options, but one option is better than the other because it's more complete. Are you good in acid-base disbalance interpretation? Nobody needs help?
Yes, Professor.
We can move? Is somebody asking help in this area? No? Everybody understood the explanation?
Yes.
Okay. A client has a chest tube inserted immediately after surgery for left lower lobectomy. During the repositioning of the client during the first post-op check, the nurse notices 75 milliliters of dark red fluid flowing in the collection chamber of the drain system. What is the appropriate nursing action? Continue to monitor the rate of drainage, call the surgeon immediately, check to see if the client has a type and cross match of blood for transfusion, turn the client back to the original position. Okay, so what do you think? You know that when the patient
Is
has
A? A.
so everybody is agreeing, no? Is until now everybody is saying A. Okay, so when you have a chest tube, the chest tube, okay, could be draining liquid, not only is for pneumothorax. Yes, in this case, the first chamber is going to be the collection chamber, and you are going to have there liquid accumulated. Okay, liquid accumulated. So the first chamber is this chamber that has the area of collection of the liquid. And then they say when you change position the patient, because patients need to be changed of position, you notice that there is 75 milliliters of blood, dark blood, okay, flowing in the collection chamber. And it is a, let me find if I can find a dark blood, okay, 75 milliliters, okay. So it is a normal amount because it is said that a flow of 75 to 100 milliliters per hour is expected because it is not bright red, okay? It is expected, blood coming out from the surgery. The surgery, that's why they leave the tube, because it's produced also bleeding. And it is not active bleeding, it is unexpected, okay, drainage. So the amount is okay, and the aspect of the blood is okay. So this should be, I agree, is continue to monitor the drainage because it is a normal amount and it's not active bleeding, it's residual blood of the surgery, which is expected. And that is the reason for those drainages. The others are the same. Call the doctor immediately, check for transfusion. Okay, it's the same. What means that in this case would be too much blood. Okay, active bleeding. So it is active bleeding, these two. So B and C is the same. So for the strategies, being B and C the same, okay, it being the question, what is appropriate? Being B and C appropriate if there is active bleeding. If there is active bleeding, important bleeding, B and C are correct, are appropriate, but cannot be the answer because it's the same. Because you need to do B and you need to do C. They are not asking what you do first. They are doing what is appropriate. So you need to do B and you need to do C because both are appropriate if it is an active bleeding. This is not an active bleeding. Why? Because the amount is not beyond the limit and the aspect of the blood is residual blood post-surgical. The surgery produced blood, bleeding is expected, but it is going to be a residual blood, a dark blood. Okay, that's why. And you need to change position of the patient. If the change of the position facilitate the drainage of the liquid, it's okay. It's okay. As far as the liquid is as expected liquid. So this is the explanation of this question. If you have doubts, if you notice that my explanation is not enough to clarify the question, please discuss that with me or ask me. The client is diagnosed with cystic fibrosis. You need to know what is cystic fibrosis. The nurse would expect the client to be treated with oral pancreatic enzymes. By the way, the name of this pancreatic enzyme is pancreolipase, because this is how appears in the Nclex in other question. Pancreolipase is the name, the genetic name of those pancreatic enzymes that are used in the treatment of the exocrine pancreatic insufficiency that presents in patients with cystic fibrosis. So they are asking which type of diet is recommended in this patient. And you have those options. So what do you think is the best diet for this patient with cystic fibrosis?
Yeah.
B.
A.
High protein, you say B, gluten-free? B as in boy? Okay, I think I heard B as in boy. In which condition we use the gluten-free diet?
Celiac disease.
Celiac disease. Celiac disease is different from the cystic fibrosis. Cystic fibrosis is a hereditary disease, recessive, in which there are two organs affected, the lungs, which is the most severely affected, and the pancreas, the exocrine pancreas. The endocrine pancreas has no problem. There is no diabetes in cystic fibrosis, but the exocrine pancreas is dysfunctional, and for that reason, the food is not digested properly. That's why it need to be given the pancreatic enzyme with each meal. The celiac disease is different. The celiac disease is an autoimmune disease in which the ingestion of the protein gluten, gluten, is going to trigger antibodies that damage the intestine, the mucosa of the intestine, the villi of the intestine. And the patient can digest but cannot absorb. Both conditions, cystic fibrosis and celiac disease, produce maldigestion and malabsorption, each one. So the consequence, and both are common in children. So the consequence that the child is developing malnutrition, yes, and they are going to have steatorrhea, presence of fat in the poo, and deficiency of vitamins, especially A, D, and K and E. But they are different diseases. The gluten-free is for celiac disease, which is the treatment of the celiac disease. The maldigestion and steatorrhea or the cystic fibrosis is treated with pancreatic enzymes, artificial pancreatic enzymes, given with each meal. So they are different. Okay. The dairy-free is mainly for the lactose intolerant or any person that had diarrhea. And sodium restriction is for the people with heart or renal problems. So this is no, and this is no. So the answer is either ruling out or knowing that those patients have malnutrition, needs calorie, and needs protein, is the best option is A. But the secret is to give those pancreatic enzymes with each meal, each time the patient eats with each meal. Today's prothrombin time for a client receiving warfarin is 20 seconds. It's a strange question because usually we work with INR. The normal range listed by the lab is 10 to 12 seconds. What is the appropriate nursing action? Recognize there is a therapeutic level, assess for bleeding gums or IV sites. Notify the healthcare provider immediately, observe the client for hematoma development. We couldn't hear
assess.
You said
B,
what?
B as in boy.
Oh, B as in boy.
Yeah.
And why? Let me something. The person that said B as in boy. Why you choose B as in boy and not D as in David? Because from my point of view, it's the same. It's bleeding.
Well, obsessing and observing, I believe, are two different actions.
I couldn't understand you. Can you repeat?
Because when you assess, you look for irregularities in the sites, and observing you could do that as well. But from what I've learned from ADPI, I believe that assessment is the first action that you need to take.
Yes, assessment, but observing for a development of hematomas is also an assessment. If you are seeing with your eyes a person and you notice that they are developing of a hematoma or hematomas, is also assessment. So if a person has a bleeding tendency, could be bleeding in the gums, and could be also bleeding in the skin or in the soft tissues. The bleeding in the soft tissues produces hematomas, bruises, etc. But ¿cómo se llama? Assessment of the gums is another side that could be bleeding. So I really don't see a difference in the person with the bleeding tendency. I don't see the difference between B and D, because both are assessment and both are assessment of bleeding. And it is an important strategy. It is an
eliminate it.
For me, you can see bleeding in the gum or IB side more rapid in the development of the hematoma.
It is overthinking. It is overthinking. So sorry, it is overthinking. It is overthinking. It is too precise. It's more rapid. It's more rapid to see bleeding in the gums or the venipuncture than observing how the patient develops hematoma in the body. It is semantic. It is overthinking. It is the same. I rule out these two because they are the same. For me, are the same. If I were in my test, I rule out these two because for me are the same. Both are manifestation of a bleeding tendency. The opposite. And also, if the patient has bleeding tendency, you need to notify the provider. If you consider that this is bad, if you consider that this value in a patient taking warfarin is bad, you need to assess for bleeding and you need to notify the physician. Those are the interventions. If you consider this value is no good, is bad, is too much second. The other possibility is the opposite. Is it, well, if the patient is taking warfarin, a prolongation of the time in seconds of the coagulation is expected. Not too much, not too little, but it's expected to be prolonged. Okay? How much you expect to prolong the time of the coagulation in a person taking anticoagulants? Around 2 times. From 1.5 to 2.5. You know that? Díganme, do you know this or not?
Yes.
Say, be honest with me. I'm not testing you. I'm not grading you. They say, yes, no. Yes or not. ¿No se acuerdan? You don't remember that? Okay. So when you coagulate, if you are not taking anticoagulant, no anticoagulant, you coagulate in certain time that is measured in seconds. Depending of the anticoagulant that you are receiving, you can test that with the time or the prothrombin time, PT, or you can measure that with the time of the partial thromboplastin time. Both are times. Both are measured in seconds because it's a very rapid coagulation. But when I administer a blood thinner, an anticoagulant, my purpose, the intended, the desired, okay, action or outcome is to prolong this time. So now it's taking more seconds, more time. You understand? Of course, not too much, not too little. There is a range. And this range is prolonged this time no more than 2.5 times. So when you have a person not taking heparin, for example, the PTT is around 30 seconds, 26 to 34, but around 30, okay? Because 26 to 34, the middle of the range is 30 seconds. So if you prolong that 2 times, okay, you have 60 seconds, which is okay, in this case, it's not heparin, okay? It's not heparin, it's warfarin. So the patient is taking warfarin. The usual lab report is 10, the normal, 10 to 12 seconds. So me, person that are not taking warfarin, we do the PT, and it's going to be 10, 11, or 12. And I'm going to prolong that from 1.5 to 2.5. Okay, let's see 2.5. So I multiply this 2.5 is going to be 25 seconds. Yes, this is going to be 25, 2 por 5 es 10, llevo 1, 5, 2, 1. Okay, is going to be 62. Okay, no, 62 no, ¿qué hice yo, Vallin? 50, yeah, 62. Okay, and the patient is having 20 seconds. Okay, so if you multiply that twice, okay, it's going to be 20 to 24, no? To make it simple, to avoid taking the calculator. Okay, if I prolong that two times, is 2 times 10 is 20. 2 times 12 is 24, 20 to 24. Okay, so is this in range? Yes, it's in range. It's not too much. Yeah, it is not too much because you expect to prolong around 2 times, okay, the time of the patient. The normal time is 10 to 12. Multiply that 2 times, 20 to 24. Is this in the range? Is in the range. So you need to decide between A or ABC or BCD. B, C, and D are the same. That is too much. A, normal range. And even without knowing this, you need to know that A, B, and C refers to the answer if the patient is having too much anticoagulation. The patient is having toxicity by warfarin, while A is only one option for normal range, therapeutic level. So if you analyze, B, C, and D are the same. Is what you need to do, what is appropriate, okay, in case of too much warfarin. While A is appropriate if it is okay, it is a therapeutic level. So by strategy, without knowing the answer, that you should know the answer, by strategy, you can answer this question. B, C, and D is the same and apply for too much warfarin. Too much warfarin. A is another option and apply for okay amount of warfarin. Okay, if this, and this is the same, because you need to do it are appropriate. The 3, B, C, and D are appropriate intervention. If there is too much warfarin, need to be A. The answer need to be A. But apart of that, you need to know, you should memorize that more or less you prolong the time, the normal time of coagulation around 2 times the normal time. They are saying the normal time is 10 to 12. So prolong that to 20, 2 times 10, 20. 2 times 12, 24. Is the actual value of the patient 20 seconds in this range? Yes, it's in this range. Okay, so A is the answer of this. It was enough explanation. Can we move?
Yeah, that was actually really great.
It's clear now? Okay. So there are 2 learning here. First, what is expected in anticoagulation to prolong the prospective coagulation time around 2 times. And second, conchale, strategies. The nurse is caring for a client in the late stages of amyotrophic lateral sclerosis, ALS, also called Lou Gehrig disease, which finding could the nurse expect confusion and memory problems, loss of half the visual field, tonic-clonic seizure, shallow respiration.
D.
You say D as in David.
Yes.
Okay. Everybody agrees? Okay.
Yes.
Everybody agrees. Okay. So this is a degenerative disease. It's not hereditary. It's not autoimmune is degenerative of unknown etiology, in which the neurons that move the muscles degenerate. So the muscles are not going to move anymore and are going to shrink. Because we use muscle to breathe, this is going to affect the respiration. The patient cannot move at all, and the patient cannot speak, cannot swallow, can do nothing, but the mental activity is totally normal. Sensation, autonomic nervous system, and mental cognitive functions are totally normal. Okay, so no confusion, totally normal. No sensorial problem, normal vision, no seizures, but yes, respiratory insufficiency. There is no treatment for this disease. There is no rehabilitation for this disease. This is a patient that doesn't benefit from rehabilitation. There are many questions about this disease. One of these is that doesn't improve with rehabilitation. Is a patient with high risk of suicidal, because it is a disease that progresses in years. So if you are diagnosed today, you still can move, you know. So, but you know what is your future. Okay, very good. The nurse is teaching the client with chronic renal failure about medications. The client questions the purpose of taking aluminum hydroxide. What is the best explanation for the nurse to give the client about why the doctor orders aluminum hydroxide? Aluminum hydroxide increases your urinary output. Aluminum hydroxide decreases serum phosphate. The drug will control your gastric acid secretion. The aluminum hydroxide will reduce potassium. What is the answer?
B as in boy.
B as in boy. It is a phosphate binder medication. So aluminum hydroxide, the calcium carbonate, the calcium acetate, and the sibelamer are all the ¿cómo se llama? The phosphate binders that are given in renal failure, in chronic renal failure, to improve the hyperphosphatemia that they suffer. And the most basic is aluminum hydroxide. Aluminum hydroxide produces a lot of constipation. Is another question that have been anchored about aluminum hydroxide. The patient is having constipation. What medication could justify this constipation? Is a patient is taking aluminum hydroxide. A mother asked about expected motor skill development for her 3-year-old child. 3 years, oh, cool. Which activity is considered a typical motor skill for 3-year-old? Tying shoelaces, riding a tricycle, jumping rope, playing hopscotch.
B.
B.
B as in boy.
So remember that 3 years tricycle, 3. Okay, it is. They also can make at 3 years can draw a circle. Okay, they can help at 3 years dressing and undressing with a lot of difficulties. They can stand in 1 foot. Okay, they can stand in 1 foot, but they cannot jump, cannot hop. Okay, hop 4 years or older. So jumping, okay, jumping or hopping, hop in 1 foot, but they can stand in 1 foot. There's some of the stuff that I seen in 3 years old. They can, of course, throw a ball, but probably is going to fail catching the ball. Okay, a client has been prescribed dexamethasone by mouth daily for a transplant rejection prophylaxis. The client asked the nurse for more information about this medication. What information should be included? Take the medication with food, yes or not? No idea. Okay, what medication is dexamethasone?
It's a cortisone.
It's a glucocorticoid. You need to know that glucocorticoids are very strong for the stomach. Glucocorticoids, the same as the NSAIDs, which is other group of medication, but is also very hard for the stomach, should be taken with food. Glucocorticoids and NSAIDs must be taken with food. In the case of the glucocorticoids, should be taken with the food of the morning, because glucocorticoids are better taken in the morning. Most of the dose should be taken in the morning. All or most of the dose should be taken in the morning, but with food to prevent the gastric aggression. So it is correct. Take acetaminophen for minor pain of aches. Yes or not? A patient that is in for transplant rejection prophylaxis, I don't say which transplant, is taking glucocorticoids. Can they take Tylenol for minor pain or aches? Okay.
Will that put too much strain on the liver?
Why you are concerned about the liver? There is no reason to be concerned about the liver. They don't say that it's a liver transplant. And second, acetaminophen in therapeutic doses is not hepatotoxic. Acetaminophen is hepatotoxic in toxic doses when it's more in adult more than 3 or 4 grams. Yes. So be aware that it's true. Acetaminophen overdose, toxicity, overdose is bad for the liver. Yeah. But in therapeutic doses, okay, it's not bad for the liver. So when they say take acetaminophen for minor pain of aches, is not in overdose, it's not in toxic doses, and the usual dose. So it is a safe medication. It's the medication that is given because it's better than any other medication for pain, fever, etc. It's the medication given to children, to old people, medication given in patients that have, delicate, okay, problems, because it's safe. It's a very safe medication. That's why it's over the counter. The problem of the acetaminophen in the liver is when there is toxicity, when there is too much amount. It is not implied there. When a doctor say to a patient, okay, take Tylenol for minor pain, aches, okay, it is expected that it needs to be taken in therapeutic doses. If they say the patient is taking more than 4 grams of acetaminophen per day, it is a toxic dose, more than 4 grams, okay? You might experience an increase in weight, yes or not?
Yes.
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 The glucocorticoids make you gain weight. Remember Cushing. When you think glucocorticoids, remember what you studied in Cushing. Avoid dairy products.
No.
So what is important in dairy products? What two stuff are abundant are rich dairy products? Protein is one, and the other is what?
Calcium.
Huh? Couldn't understand you. I'm so sorry. You need to be very patient with me, very compassive with me. Be compassive with me. I don't understand a word what you say. It's because I'm deaf, or my microphone is really horrible, or your microphones are really horrible. But I don't understand a damn of what you say. And I don't understand, sorry. So be compassive with me, repeat, don't be upset or annoyed by my, say again, because I don't understand a word what you say.
Calcium, Professor.
Calcium, okay, I understood that, calcium. So a patient with steroids have problem with the calcium.
No.
Yes.
Yes.
Produce osteoporosis. The glucocorticoids is the medication that produces most osteoporosis when they are taken. So maybe some of you have not clear that in Cushing disease, you have osteoporosis, yes? And you have brittle bones. And when you have osteoporosis, a diet rich in calcium is recommended. Are you clear? Say yes,
Yes.
say no, okay. Ay, mira, milagro, gracias a Dios mío. Una se dignó a decirme yes, okay. Yes, and I'm noticing that the culture of Miami Regional University. Okay, the aloofness of my students and the the lack of with some section. Okay, yes. So avoiding dairy product doesn't make sense. So it is a no. But it is a reason no with the explanation that I made that maybe you can apply this knowledge in the next, okay, in the next situation. Do not stop taking this drug abruptly. Yes or not?
Yes.
Yes, of
Yes.
course. You know that can produce adrenal insufficiency. Very good. Okay, this is another way of practicing those topics. In Nclex, they are going to test you whatever have been taught to you in the career. Okay, the stuff that you remember, the stuff that you don't remember, but those are going to be the questions in your English, are not going to be rocket science, are going to be the stuff that have been taught in your career. Okay, on the second day of hospitalization, the nurse needs to assess gastric placement of a nasogastric tube prior to the administration of a bolus of enteral feeding. What is the priority action the nurse should take before starting the feeding? Check the pH of the aspirate, review the X-ray report when the tube was inserted, auscultate the abdomen while instilling 10 milliliters of air into the tube, place the end of the tube in water to check for air bubbles.
A.
Correct. The only possible answer to this question is the pH. Why not the X-ray, which is the best? Because 2 days ago was made the X-ray. So this X-ray was very valuable at the moment of the insertion, but not 2 days later. So the best in this moment is that we don't use this or this anymore. Good. It's important to know that for your Nclex. A nurse is working on an OB gynecological clinic. A 40-year-old woman in the first trimester of an unplanned pregnancy provides a health history to the nurse. 40 years, first trimester of an unplanned pregnancy. Which information should receive priority attention? She has taken 800 micrograms of folic acid daily for the past year. She was diagnosed with type 1 diabetes and received insulin. Her husband was treated for syphilis when adolescent. She had been taking lisinopril for her blood pressure for the past 2 years.
D.
What is the as in diamond?
Yes.
Yes.
Okay, the as in diamond. Okay, so is the most important. Lisinopril and all the ACE inhibitors and the ARBs are teratogenic and are contraindicated in pregnancy. Okay, in pregnancy. The fact that the husband was treated with syphilis when adolescent doesn't mean that has syphilis now. Syphilis successfully treated with penicillin. The fact that is with diabetes and he received insulin is okay. It's important, but it's okay. This is the treatment of the diabetes during pregnancy, insulin. And taking folic acid is good. The concerning situation here is the lisinopril. This lisinopril should be discontinued and replaced by other blood pressure medication. It is an older woman with non-planned, okay, pregnancy, okay, and this is the priority. A client taking isoniazid for tuberculosis asked the nurse about the side effect of this medication. The client should be instructed to report which of these findings, which finding should be reported if taking isoniazid. Extremity tinglings and numbness, joint pain and inflammation, blurred vision and visual halos, orange discoloration of the urine.
A.
A. The adverse effect expected and treatable, o sea, considered in patient taking isoniazid is neuropathy. The neuropathy or polyneuropathy produces tingling and numbness in the extremities. And this is the one that you need to observe in that. The joint pain, blurred vision, and orange discolorations are not related with isoniazide. And to prevent these adverse effects, that's why isoniazide is given together with pyridoxine, which is B6. Joint pain and inflammation is observed in patients taking pyridoxine, okay? Pyridoxine, okay? Because pyridoxine elevates uric acid and can produce gout. The blurred vision and halos could be a concern in patients taking ethambutol, because ethambutol is producing optic neuritis, and the orange discoloration of the urine is produced by the rifampin. The rifampin, ethambutol, pyridoxine, and isoniazide are the first line, together with streptomycin, that is not mentioned here, for the treatment of tuberculosis. And each one have a specific adverse effect to have in mind. A nurse is caring for a client diagnosed with chronic obstructive pulmonary disease and who becomes the snake. The nurse should take which action when the patient with COPD becomes the snake? Administer oxygen at 6 liters per minute via nasal cannula. Place the client in low Fowler position. Inhale glucocorticoid nebulizers and rinse the mouth after it, as it declines to do pursed lip breathing.
D.
So the pursed breathing is the therapeutic respiration that improves the oxygenation in patients with COPD. This is too much oxygen, it should be in high Fowler position, no low Fowler. The glucocorticoids are not indicated in the acute decompensation of those problems, because glucocorticoids produce bronchoconstriction. Are given prophylactically, but not.
Is beta-2 agonist?
You give beta-2 agonists. You give albuterol or salmeterol or formoterol in COPD. Or you give anticholinergic, ipratropium, okay? So you can give albuterol to this patient for improvement. You can give ipratropium for bronchodilation. So for bronchodilation, albuterol or ipratropium, okay? In this case, oxygen, but not so much. So 2 liters is enough. High Fowler position, yeah, and promote pursed lip respiration. Steroids in this moment is not appropriate. Why? Because inhaled steroids should not be given in the acute decompensation, neither in asthma or COPD, because inhaled glucocorticoid produce bronchospasm. That's why the glucocorticoid should be given after inhaling albuterol, because they produce bronchospasm. First, a bronchodilator before the regular, routinary, okay, around the clock prophylactic administration of glucocorticoids. Okay, so that's the analysis of this question. It's clear, but yes, can be given albuterol and or ipratropium in the patient with COPD with decompensation with this dyspnea as a bronchodilator. The other bronchodilators are the long-acting beta-2 agonists, like the formoterol and salmeterol, that are given in COPD, but not in asthma. Take care, in asthma, we don't give LABA, long-acting beta blockers, okay? Beta agonists, sorry, because can produce increased mortality. The nurse is taking care of a client with chest tube inserted after thoracic surgery. Similar to the previous. Which of the following finding must the nurse give immediate follow-up? So what is wrong? The drainage in the collection chamber has reached 200 milliliters in the last 4 hours, so 50 milliliters per hour. There is a continuous vigorous bubbling in the suction chamber. The drainage has changed from pseudosanguineous to red, and there is an intermittent bubbling in the water seal chamber. So let's start ruling out. Intermittent bubbling in the water seal is correct, yes? So we rule out this. The change from pseudosanguineous to red suggests starting bleeding, no? To start bleeding. So suspicious, no? The bubbling in the suction chamber could be continuous. Should not be vigorous, should be gentle. But
Gentle.
what is worst? That there is a vigorous bubbling in the suction chamber, or the patient is bleeding. It should be my conundrum, my dilemma in the test. And having 50 milliliters per hour is okay. Less than 100, 75 to 100 milliliters per hour is okay. So it's between B and C. So B says there is too much pressure of suction in the suction chamber. This is not necessarily something life-threatening or could produce a serious problem. Is just because, remember, there is always a valve of relief of the suction pressure, and that's why the bubbling is vigorous. Is because the valve is releasing the pressure, the negative pressure that is too much. So the pressure should produce a gentle, continuous bubbling, not a vigorous bubbling, but it's not a life-threatening condition because the valve is protecting. So what is happening, there is an unnecessary amount of suction in this patient. It's going to wear out the water of the suction chamber before time, and there is a waste of pressure in there. But the change from serosanguineous to red, okay, not that here I don't see any mention about the characteristic of the red, or the qualifier of the red, but it's from serosanguineous was not red, was serosanguineous like pink, and water with pink, with red blood cells, to red in a patient that had surgery, and it is a change. Changes always need to have follow up, no? So it looks that is worse. C is worse, more risky than B. You understand? And this should be the best answer, no? That the patient is bleeding. So what you do, you check vital sign, and you make assessment. And if you notice any evidence that the blood pressure is going down, there is an unexplained tachycardia, and you see that persists, okay, a high flow of blood from the drainage, then you call the doctor because the patient could start bleeding. And bleeding has priority over reduction of the suction pressure in the suction chamber. Are we agreeing? Yes? Can we move? Okay.
Yes. Yes.
So this is the way that I suggest you to approach the question systematically, calm, okay? Doing that, okay. Which of the following findings in a client with COPD requires the nurse follow-up? Hematocrit 54, PCO2 50, pitting edema in both legs, saturation 89%. What needs more follow-up here?
B as in boy.
Okay, the CO2 is high. It could be a possibility. Okay.
I would say D.
D as in David, autosaturation low. Okay, low. Okay, so it is not K. It is not K. The hematocrit, you discard that. And what about the pitting edema?
Yes.
Also. Okay, it's no good. Okay, so now we need to decide. This is our Nclex. This is the Nclex. We are in the Nclex. We have this question. And okay, hematocrit is high.
I would say between the C and B.
Like the 2B and D, okay.
No, C and C, and then D is expected.
C is expected?
D.
Well, I would think that
oh,
B and D
yeah,
is
B is expected. Okay, so very good. So we are good. We are understanding. But what I want you to understand also is that be prepared for your English to have this situation that we have in this moment. Yes, and this is the way that you need to approach the question. Okay, I can rule out in this case the hematocrit because nobody is going to die of having a high hematocrit. So the CO2 is high, but it's a patient with COPD. So high CO2 is expected in COPD. Yeah. Okay, and this range is not extreme. is a common finding in COPD around the 50s, okay? Because they have COPD, they cannot change that. Only a lung transplant can change that. How they compensate these high CO2, they produce more bicarbonate. They compensate this respiratory acidosis producing more bicarbonate. This is the kidney compensation. So that's why the advantage of having a chronic disease, they can compensate. And the oxygen is low. The oxygen is low. Nevertheless, remember that the normal values in COPD are different from the normal values in regular people. So having a oxygen in 89 is not normal. Could be improved with 2 liters per minute of flow the oxygen, but is neither okay a extreme value. So being around 90% in COPD is like the usual, around 90. So is the usual. What means pitting edema in both legs? That is retaining fluid. No?
Congestive
Heart failure.
failure.
Heart failure. And it could be a complication of the COPD, heart failure, because they develop something called cor pulmonale, no? Something called cor pulmonale, and it is a heart failure. So it is a complication. It is a complication, you know? It is a complication. And then you need to check if there is a hepatomegaly, if it is neck vein distension, etc., etc. Because then is another condition, another disease added to the COPD, complicating the COPD. So this is the scenario. This is the kind of question that we are facing sometimes in English, you know? Those are not necessarily the diseases of decisive questions that could make you fail or pass the English, but it's a question that you can, if you guess correctly, give you point. Because the elevated CO2 and the low oxygen until certain limits are expected, okay, alterations in COPD. Having the CO2 around 50, from 45 to 50, and the O2 saturation from 89 to 90, 91 is the usual, okay? And for this CO2 in 50, what we can do is to give bronchodilators and pursed lip respiration. And for the O2 saturation low, give 2 liters per minute of oxygen. But having pitting edema in the legs is to think that is a complication. And generally what we follow up are not the expected findings, are the non-expected findings, okay? Which are the complications. In this case, it's a cor pulmonale, okay, complicating the COPD. I favor the option C for the reason that I explained. But be prepared to have this kind of situation, and you need to very calm, analyze whatever you know. Is this expected? Is this too high? Is this too low? So now maybe what we learn is that in COPD, it's not rare to see PCO2s around 50 and O2 sat, okay, around 90. Maybe it's a knowledge that you need to know, because sadly, those persons has destroyed lungs. They survive because there are chronic conditions and they compensate. Precisely, this hematocrit is to compensate the chronically low oxygen, because now they have more hemoglobin. Yeah, now they have more hemoglobin. It had 17 in this case, 17 grams of hemoglobin. The nurse delivering a conference about risk factors of lung cancer should include which of the following factors? Okay, risk factors for lung cancer. Zero apply. Family history of lung cancer.
Yes.
Yes.
Always genetics in cancer is important. I should also answer yes, because always genetics is important. History of working a coal mine.
Yes.
Okay, you need to know that this powder that those people inhaled also, produce on chronic diseases in those patients, the same as the asbestos, okay? And it is a risk factor. Alcohol intake.
No.
Yes.
No, it's not related with lung cancer. Alcohol intake is related with all the cancer you can imagine, but it's not lung cancer. Mouth cancer, esophagus cancer, stomach cancer, colon cancer, breast cancer, pancreatic cancer, liver cancer.
Cirrhosis.
Huh? What?
Yes, cirrhosis, liver cancer. You say.
Oh, yes, because in liver cirrhosis brings to liver cancer. Even cervical cancer, imagínate. No, but it's not mentioned in lung cancer. Secondhand smoking.
Yes.
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 Cystic fibrosis. No, it's not related cystic fibrosis with lung cancer. Exposition to asbestos. Yes. Okay. It is a part of the smoking. Other risk factors. Are we good? So I had a tendency to always accept genetics as a condition that predisposes you if exposed to environmental, factors, predisposed to increase your predisposition to have cancer, many type of cancer. So as a routine, I always select the genetics as yes, because it's really, really, really very common, and nobody can deny that. So it's a suggestion. I see that genetics appears frequently in risk factor for cancer, and it's my suggestion. I never deny genetics as a risk factor because it's real. It's something that you cannot refuse. The others are a little more difficult. In this case, the polemic is alcohol. Alcohol is a super important risk factor for cancer, for a lot of cancer, but it's not mentioned in lung cancer. But all the rest cancer that we mentioned is important. Breast cancer, alcohol is a risk factor. Breast cancer, cervical cancer, the colon cancer is mentioned, alcohol. So yes, alcohol. There are two stuff that are mentioned as risk cancer in many cancers. Is obesity and alcohol. But neither obesity nor alcohol is mentioned in lung cancer. Why? I don't know. But it's something that I read before. But incredibly, obesity is ovarian cancer, endometrial cancer, breast cancer, colon cancer, ¿cómo se llama? Pancreatic cancer, are obesity, being gordo. So be prepared for that. In alcohol, they put the American Cancer Association put the alcohol in practically all cancer, but not in lung cancer. Good. You don't need to know everything, but you need to know a little. And knowing these basics about cancer risk factors is very important. The nurse is changing the dressing of a client with a subclavian central venous catheter. Which of the following is incorrect? The nurse places the client in a modified Trendelenburg when changing the tubing. The nurse cleans the catheter and the surrounding skin with chlorhexidine. The nurse trims the hair of chest with a pair of scissors. The nurse flushes the catheter with a 20 milliliter syringe. What is wrong here?
Sí.
Why C? What is the rationale? Di lo que piensas. Say what you think. Don't be.
Did as in David.
This is in David.
Yes.
Sorry. Diaz in David. Okay. Why flushing with a 20 milliliter syringe is bad?
Because it's 10.
No. Should be 10 or more. What cannot be is less than 10. The rationale for that is for a physical law that say that the pressure is inverse proportional to the radius, okay, the diameter or the radius of the cylinder. Syringes of less than 10 produce too much pressure when pushing the plunger and can break the catheter. When it's less than 10, but could be 10 or more. Are we good? So you added a new clarification. You added, okay, you completed the concept. So 20 milliliters is okay. Okay, 10 milliliters is okay. 5 milliliters is not okay. So it's not D. So it's not D. Okay, let's start ruling out. Cleaning the catheter and the skin when you change the dressing with chlorhexidine is good or bad?
Good.
It's good.
It's sterile.
The prefer antiseptic in this moment in cleaning is chlorhexidine. So it's good. Cleaning the catheter and the surrounding skin. What means cleans the catheter and the surrounding skin? You are going to scrub, okay, the site of the insertion of the catheter. Okay, you are going to scrub, okay, the scrub with chlorhexidine, and you are going to wipe the catheter from insertion away, It is correct, and you do that with chlorhexidine. This is correct. So don't be too squared than you say. The nurse cleans. I know it is a sterile procedure. No. The nurse is doing that with sterile gloves, and is not spitting or breathing. Is wearing a mask, etc. But need to clean the catheter and the surrounding skin with chlorhexidine. It is done this way. Okay, what could be wrong in placing the client in this position? This position with a pillow while changing the dressing. What could be bad? Or if it is good? It is good? Is it good?
No.
No.
Why is bad? Why is bad?
Because the blood goes up.
Okay, this avoid air embolism. When you are doing that and you are, for example, changing the tubing, in the moment, suppose that the patient is unconscious and has a central cut, the patient cannot bear down, etc. When you remove the tubing that should be changed every 24 hours, the tubing and the bag should be changed every 24 hours. You remove the tubing from the catheter. If the patient breathe in this moment, air can enter through the catheter. So one way that you can do to increase the pressure of the blood in the vein in a way that air cannot enter is elevating the legs of the client. It is going to displace the blood pool in the lower extremity toward the inferior and superior vena cava, and then the pressure of the blood in the vena cava is going to be higher because the position, and is less possibility for the air to enter passively there. This is also the position in which you will place the client. This is also the position in which you are going to place the client for the doctor to introduce the catheter. When the doctor say, nurse, prepare the client to insert a central catheter, you place the client in this position. You place the client in flat in bed, okay, with elevation of the legs. With which purpose? It is to make the vein full with blood, because the blood is going to be displaced in this direction. The pressure of the blood, the venous blood, is going to be displaced in this direction. You understand? And it's going to be easier for the doctor to find the vein and to pierce the vein, the subclavian vein. When you get a vein in the arm, the forearm, you place a tourniquet to engorge the vein and make it easier to pierce. You cannot do that in the subclavian vein. You cannot place a tourniquet in the chest of the client, but you can elevate the legs to increase the pressure of the blood in the veins in this area and facilitates the intervention. And this is also a way, if the patient tolerates the position, of course, of preventing entrance of air, because the pressure of the blood is going to be increased and then air would not be able to enter. So this position is correct. So need to be C. By ruling out, okay, discarding options must to be C. What could happen? What could happen, okay, in a patient that is hairy, no? Okay, has a catheter inserted here, is a catheter inserted here, but the patient is very hairy, okay? And then, ¿cómo se llama? You are trimming the hair around the side of the insertion with a pair of scissors. What could happen?
Professor, but don't you cut the hair with the shaving machine?
Okay, but why would you first don't answer my question? This is a drawing here of a hairy chest of a patient with a central catheter and a pair of scissors. What could happen when you do that?
Gonna have hair.
¿Cómo es la
So it's
cosa?
not gonna stick. It's not going. It's gonna be in the
No.
way. Hair is going to
The
be.
scissor can damage the catheter.
Oh, finally, somebody had a critical thinking to understand there is a risk of cutting the catheter by accident.
So you use a clipper, right?
Yes, you use something that is not going to harm the catheter. But I think that even if the drawing is bad quality drawing, you can visualize the risk there. And this is the kind of stuff that Nclex is exploring your common sense. No? Do you mind if you cut the catheter? Is going to be a minor incident or a major incident. So think a little, you know. So obviously, the purpose of this question is to explore if you can visualize, like in my dibujito, my drawing, you can visualize the risk that implies C. Option that also you can reach knowing the techniques used to flush and to change the dressing and to scrub and to position the clients for this procedure. It's just presenting you the type of question that you can be facing in your Nclex. Okay. Okay, I received information that that the students that have been taking the exam have been having problem with the question of cancer. Today, we had the opportunity of practicing some question about cancer. But I want to tell you that the most question about cancer that you will have in your Nclex are about risk factor of the most common cancers. Of course, the most expected question is about breast cancer. Female cancers are the most commonly, tested, much more than prostate cancer. But breast cancer have a lot of risk factors, but some risk factors are minor, some risk factors are more serious, no? And
sorry for interrupting. What was the answer for the last question?
oh yeah, okay.
I'm so
Who can help us about this? Who can help? What was the answer?
The incorrect answer was cutting the patient or trimming the hair.
Okay, and the rationale was made evident with a lot of expressions and comments, etc. Okay. Okay.
The answer is didn't.
Okay. I have a personal problem. If you don't understand the question, you don't understand the drawing, you cannot find by yourself the answer. The purpose is lost.
Letter C.
Okay. Okay. So in breast cancer, the most important, okay, the most important aspect are first the age. The older the woman, the higher the risk. Second, genetics. Genetics is very important. But now there are two elements in genetics that you need to understand to be able to interpret the breast cancer question. The younger the relative who had breast cancer, the higher the risk for the relative. So if you have your mother, your sister, or your daughter with breast cancer, okay, the younger this relative, because those are the three relatives that are related, the first degree relative that they have, the higher your risk. Let me explain you. You have two women. One is 60, the other is 59. So similar age, similar conditions, okay, weight, history, etc. One has the mother with breast cancer when her mother was 65. The other had her sister with breast cancer when her sister was 40. So, and they asked, of these two, which one has the higher risk? Entonces, the answer is the one that had the sister had cancer in her 40s. Why? Because the fact that the cancer appears in the 40s so early translate an important genetic predisposition. While for a woman having breast cancer when 65, it is not necessarily a ¿cómo se llama? A genetic predisposition. It's more related with the age. And the other risk factor is to being diagnosed, the other genetic risk factor to being diagnosed with either one of those genes, okay, the BRCA. And this is frequently tested in Nclex. That's what I can tell you. The other important risk factor that is mentioned is obesity. The other important risk factor that is mentioned is consuming estrogens, so taking estrogen replacement therapy. Not having babies or having the babies late after the 30s is also an important risk factor. Alcohol and tobacco appears a lot as a risk factor. Why? Because are easily modifiable, can be easily eliminated. The others it's difficult to eliminate. Okay. And then there are, less common risk factors like early menarche, less than 12, or late menopause, more than 55. Dense breast. There are women that have very dense, a lot of fibrous tissue in the breast. And you see that in a mammogram. This increases the risk factor of having breast cancer. Having personal history of breast cancer. So if you have breast cancer in one breast, the other also can develop breast cancer. Receiving chest radiation for other cancer, like for example, lymphoma, etc. No? And very important, the fibrocystic disease, that is a benign condition in young women that have lumps in both breasts that become painful and bigger before the menstruation and deflate after the menstruation, or having a fibroadenoma, okay, a fibroadenoma in the breast, are not risk factor. Those are benign conditions not related with risk factor. And pregnancies, having pregnancies, okay, and giving breastfeedings are protective. So those are frequently tested topics in breast cancer. Sometimes they ask, in which quadrant of the breast is more common the cancer? Is in the superior and external, okay, quadrant, the upper outer quadrant. This is the most common quadrant that has breast cancer. The next is retroareolar. Areola, you know, the nipple and that areola. Retroareolar, yes, is the second most common. Okay, and it's important the tail, but the frequency of cancer there is low. But it's important to not ignore this 1% and to palpate any lymph node. Okay, so the most common is the upper and lateral, upper and external, okay, outer quadrant and retroareolar. Don't forget that the patient after mastectomy has lymphedema. All the nursing care that need to be done in the management of lymphedema is frequently tested. Exercises are good, okay? Exercises are good. Range of motion, practicing sports, playing piano, doing exercise is good, okay? There is an exercise that you, with your hands, you the hands is going to behave like a spider, and then the hand is crawling, climbing through the wall with the fingers. Of course, it's very important that the person prevents any puncture, any injury, any wound, any cut there. Okay. Remember that tamoxifen is an antagonist of the estrogen receptors. It's an estrogen receptor modulator that increases the risk of DVT. That as a side effect increases the risk of DVT. Is frequently tested. Tamoxifen is used in survivors of breast cancer to prevent the recurrence of the breast cancer. You need to know if there is a picture like this, that this is the most severe and advanced form of breast cancer in which there is edema, lymphatic edema of the breast, and the skin acquires this pud-orange, okay, aspect, skin of orange, okay? It looks like the skin of the orange, okay? Also, nipple retraction is a late, okay, finding. For ovarian cancer, what I can tell you is that the risk factors are almost the same as breast cancer. So, an old woman, family history, the same early menarche, late menopause, or the use of hormonal replacement therapy, not having babies, obesity. But this is the distractor that always appears, that taking oral contraceptive, taking the pill in your youth to prevent pregnancy protects you from ovarian cancer. For endometrial cancer, again, is very similar. Older women, family history, obesity, but then there is an important risk factor, type 2 diabetes mellitus, or history of endometrial hyperplasia. Sometimes women have a very abundant menstruations, go to the doctor, doctors do a curettage, and they say you have an endometrial hyperplasia, you are going to receive certain hormones, progestin, okay? And it is a risk factor, the same as type 2 diabetes. And taking tamoxifen, so a woman who had breast cancer and is taking tamoxifen, this tamoxifen increases her risk of endometrial cancer. The intrauterus device, those copper T and those stuff to prevent pregnancy, and oral contraceptive are protective of endometrial cancer. So having this device inside the endometrium, inside the uterus, is good, protects, or taking oral contraceptive. So oral contraceptives are protective for endometrial and ovarian cancer. Those are being tested in Nclex. For cervical cancer, the acquisition of the human papilloma virus is the main risk factor. Smoking and alcohol also is related. Genetics could also be related, okay? So anything that predisposes you to be infected with human papilloma virus or HIV also is a risk factor for cervical cancer. Okay, early activity without protection, multiple partner without protection, etc., etc. Colon cancer, genetic is important. A history of polyps is important, and a history of ulcerative colitis or Crohn's disease is super important. Those are the most important risk factors are tested. A diet low in fiber and high in saturated fat, which is the Occidental diet, is a risk factor. Alcohol, tobacco, and obesity are risk factors. We already mentioned that. The ulcers in the stomach, diverticulosis, use of laxative, parasites are not related with colon cancer. Why I put that? Because in the question that have been in Nclex, those are the distractors, the one that you are not going to mark. For the liver cancer, the risk factors are hepatitis B and hepatitis C. These two hepatitis are oncogenic viruses, can produce liver cancer, and the development of cirrhosis, of alcoholic cirrhosis. For the prostate cancer, the risk factors being a man older than 50, having family history, or being African American. Prostate cancer is more common in Black people. When a woman has endometrial cancer, ovarian cancer, etc., could have a hysterosalpingo oophorectomy, in which they remove the uterus, the salpings, the fallopian tubes, and the ovaries. The important to know of this oophorectomy is that when they remove the ovaries, the woman is going to develop premature menopause and is going to experience estrogenic insufficiency. So it's going to have hot flashes, vaginal dryness, etc. Other surgery that I've seen is related with gynecology, and this is good to mention, is this surgery. It's a very common surgery in women, all women. It's called colporrhaphy. Colporrhaphy. Women, when they are older, okay, especially they have vaginal birth, tends to have genital prolapse. And this produces urinary incontinence, stress incontinence. So they are going to have a tightening of the vagina, okay? In this tightening is called colporrhaphy. It's more or less this surgery. So it's just to make you know that it is another surgery that has been frequent in Nclex, and people don't know what this surgery is about. So at the end, this tightening remove excess of the muscle of the wall of the vagina and then reattach this way, so the vagina is going to be narrower like this, de acuerdo? And of course, the post-surgical care is avoid Valsalva and postpone intercourse until the doctor, okay, authorizes that when it is totally healed. Leukemia is tested with certain frequency. You need to, the leukemia is more frequent in children. And the leukemia that is more frequent in children is related with the lymphocytes, this white blood cell called lymphocyte. And leukemia originates in the bone marrow, where a mutation of the stem cells, of the white blood cells, producing an excess of abnormal cells. For that reason, the bone marrow is going to be damaged by the cancer. And the cells that produce platelets and red blood cells are also going to be damaged. So in leukemia, we have anemia because the cells in the bone marrow that produce red blood cells are going to be damaged by the cancer. And we see low platelets because the cells of the bone marrow that produce platelets are going to be damaged. And we see a lot of abnormal white blood cells. So you can have a very high count of white blood cells, abnormal white blood cells. The diagnosis is made with bone marrow biopsy. The bone marrow biopsy is made in the iliac crest, the bone of the pelvis, yes, and the patient should be placed in lateral position. If the patient is adult, it's just local anesthesia and doesn't require being NPO. But if the patient is a child, it's going to be sedated and then it's going to have at least 2 hours of NPO. The treatment of leukemia includes chemotherapy and radiotherapy. It's not the most important aspect, but the most important to know what is a bone marrow transplant. When a patient has leukemia, doctor will give high doses of chemo and radiotherapy, and the bone marrow of the client is going to be erased. No more bone marrow. It's erased. Doesn't exist the bone marrow anymore, which is good because this bone marrow had cancer. But meanwhile, the patient is waiting for a new bone marrow. The patient needs to be in isolation, in reverse isolation, in neutropenic precaution, in bleeding precaution, receiving transfusions of red blood cells, white blood cells, and platelets, because this patient has not bone marrow. When is found somebody that has a compatible bone marrow, this person will donate the bone marrow and the bone marrow will be transplanted to the recipient. And this will cure, will eliminate the leukemia. The bone marrow, when it's extracted from the donor, is liquid, it's like blood, and is placed in a transfusion bag. And the recipient, the client that will receive the bone marrow, will receive the bone marrow as a transfusion in the vein. And it's a bedside procedure. So the day that the patient receives the bone marrow transplant will be a bedside procedure, just like a transfusion. The lymphoma is a cancer in the lymph node. So the cancer originates in the lymph node, while leukemia, the cancer originates in the bone marrow. In the lymphoma, the cancer originates in the lymphoid tissue or the lymph node and manifests by enlargement of lymph node. These enlargements of the lymph node is not painful and is progressive. The biopsy of the lymph node will demonstrate a cell that is mentioned, is tested in Nclex, that has a very weird name. You don't need to write that, but this is the name, Reed Stember cells. And this is the cell, okay? And the treatment is radiotherapy and chemotherapy with very good outcomes. The most commonly found lymphoma in young people is called Hodgkin lymphoma. The most commonly lymphoma in older people is non-Hodgkin lymphoma. The Hodgkin lymphoma is the one that has the red Stember, cells. Another topic that is frequently tested related with cancer is the emergencies in oncology. Today, we talk about the superior vena cava syndrome, and we understood that it is a compression of the superior vena cava with edema of the arms, head, and neck, brain edema with all this implication, distension of the veins of the neck and the arms, and requires radiotherapy to decompress the vein. A catheter could produce also superior vena cava syndrome. This is a patient with superior vena cava syndrome. You see how the veins of the chest are so distended and the neck is so, swollen. Is because, that this was a lady with edema in the face and coma because of lymphoma. This is after radiotherapy. Looks another person. The other emergency that you need to know in oncology that can be tested is the tumor lysis syndrome. When a person has cancer, many cancer cells, okay, and go to the first session of chemotherapy, the chemotherapy will destroy those cells all at once. It's called induction of the chemotherapy. Inside the cell, we have a lot of potassium. So this potassium is going to be released to the circulation. So there is hyperkalemia. Hyperkalemia. Inside the cell, we have a lot of phosphorus because in the cell, we have ATP. ATP means adenosine triphosphate, 3 atoms of phosphorus for each molecule of ATP, and there is a lot of ATP inside the cells. So there is going to be an increment of the phosphorus in the blood. But when the phosphorus is high in the blood, the calcium decreases. So there is hyperkalemia, hyperphosphatemia, and hypocalcemia in the tumor lysis syndrome, the day and the day after of the chemotherapy. And inside the cells, in the nucleus of the cell, there is a lot of purines, and the purines are substances that transform in uric acid. So the patient, okay, uric acid, and the patient will have the day of the chemotherapy a severe elevation of uric acid with 2 problems: gout in the joints, and so arthritis in the joints, and kidney stones. So it's important to pre-medicate the client with allopurinol and hydrate the client. Hydration and allopurinol are the way of preventing this stuff. Of course, the treatment of the hyperkalemia is with insulin and glucose and K-exhalate with sodium polystyrene. And phosphate with phosphate binders and calcium with calcium gluconate. So this is the famous tumor lysis syndrome. And the other emergency that can be seen in cancer is hypercalcemia. It's because metastasis of the cancer in the bones, releasing the calcium stored in high amount in the bones to the blood. And from the blood, the calcium goes to the kidneys, clogging the kidneys. The treatment of this is hydration, hydration, hydration to flush the kidneys and unclog the kidneys. These 3 complications of the cancer have been frequently tested in Nclex, and what intervention you expect. In relation with the chemotherapy, it's important to know that chemotherapy is a very delicate manipulation because the nurse that manipulates without knowledge the chemotherapy can develop bone marrow depression or cancer because, contamination with chemotherapy. But the patient that must receive chemotherapy is at risk of developing stomatitis. Stomatitis is an erosion or ulceration of the mucosa of the mouth that prevents the client from eating when they are in chemotherapy. To promote the eating, we are going to administer something prescribed by the doctor before each meal, which is lidocaine, which is a topical local anesthetic in gel before eating to numb the ulcer of the mouth and avoid the pain during eating. And of course, the food should not be acid, should not be too hot, should not be scraping or hard to facilitate the eating. The reverse precaution that need to be, those patients with depression of the bone marrow because the chemotherapy, the patient need to be isolated in a room alone. This room should have positive pressure of the air, and the door must be all time closed. Any person entering this room should be screened for carrying infections and should be wearing gown and face mask to protect the client. If the client needs to leave the room, is going to be wearing face mask. In the room should not be anything that could be contaminated with bacteria, like for example, salads, like for example, fruits, or any raw food, sushi, etc. And no pets should enter, no flowers, plants, and etc. Remember that chemotherapy is a vesicant. If for any reason there is an extravasation or infiltration of the IV chemotherapy, you should stop immediately the infusion and with a syringe try to suck back, try to suck to remove the highest amount possible of blood and liquid from the site of the extravasation. So don't remove the IV catheter that is out of vein, okay, but is precisely in the site where the vesicant has been spilled. So don't remove the IV catheter. Even if you know that it's out of vein, don't remove the IV catheter. The pharmacology of the medication used in chemotherapy is tested with certain frequency. The most common chemotherapy that you will have in your test are the cyclophosphamide, vincristine, cisplatin, trastuzumab, doxorubicin, and bleomycin. It's something difficult to learn, but I suggest you to make an effort. I had in my two Nclex, in the LPN and RN Nclex, questions about chemotherapy. All those chemotherapies produce bone marrow depression, produce stomatitis, risk for vesication, etc. All have that in common. Produce all of them a lot of nausea and vomit. You know that for those nausea, the medication that are used are this type of medication, ondansetron, brand name Sofran, ondansetron, or granisetron. Notice that they end similar, etron, yes, citron, okay? So ondansetron or granisetron, both have been in Nclex, okay? And this is the preferred medication for the nausea and vomits induced by all those medications. Those medications for the vomits should be given before the chemotherapy, not after the chemotherapy. And this is the most important. When the bone marrow is depressed by the chemotherapy, the white blood cell count will decrease, and the medication that is given the day after the chemotherapy to elevate the white blood cells is called filgrastim, also frequently tested. And each one of these chemotherapeutic agents have a specific toxicity. The cyclophosphamide produces the cyclophosphamide, which is abbreviated CY, produces cystitis, hemorrhagic cystitis. The vincristine, okay, the vincristine produces peripheral neuropathy. The cisplatin is the same as the aminoglycosides, ototoxicity and nephrotoxicity. The trastuzumab, which is the medication used more commonly now for severe form of breast cancer, is cardiotoxic, the same as the doxorubicin. The trastuzumab and the doxorubicin is cardiotoxic. You need to do test of the heart, EKG, echocardiogram. And the bleomycin is toxic for the lungs. There is a mnemonic that is, for me, my point of view, very useful. You draw a snow man, and then you use the Z of cisplatin to make the ears and the kidneys of the snowman. Okay. This is to remember that cisplatin, that starts with C, is ototoxic and is nephrotoxic. Then with the CY of the cyclophosphamide, you make the urinary bladder, the urinary bladder and the urethra. Yeah. To remember you that produces cystitis. With the D of doxorubicin, the D of doxorubicin, and the T of trastuzumab, you make the heart, right atrium, left atrium, right ventricle, left ventricle. To remember that both trastuzumab and doxorubicin are cardiotoxic. With the B of bleomycin, you make the two lungs at both sides of the heart to remember that bleomycin is have pulmonary toxicity. And when the V of V increasing, you make the extremities to remember that the peripheral neuropathy is experienced mainly in the extremities, producing numbness and tingling in the extremities. So this is a good way of remembering the side effects that are the most commonly tested for the medication for chemotherapy. Here is a little better represented. In radiation, you have two types of radiation. The beam radiation, also called teletherapy radiation. In this case, it's like an X-ray. I don't know if you know what is an X-ray or happening in an X-ray. The patient is going to be taken to a special place where there is a linear accelerator or cobalt pump, okay? Now the most common is the linear accelerator. It's a machine like the X-ray or the CT scan that produce gamma rays that are going to be centered in specific areas of the body that require those marks, okay, in the skin made by the radiologist or the radiotherapist. And then the patient receives the radiation. It's just seconds, fractions of seconds in which the machine is turned on and the radiation is in the environment. The patient will be alone receiving the radiation for seconds in the room protected by LED, okay? And then when the machine turns off, the patient is not radioactive anymore. It's important to know this question that the patient can just be cared by a pregnant nurse. When this patient returns to the service, to the nurse, the patient is not radioactive. Those patients have no radioactivity, so can be cared. Patients in radiotherapy, in beam radiotherapy or teleradiotherapy, can be cared, okay, by pregnant nurses. The patients are not radioactive. An interesting side effect of radiation, the radiation, is that the skin can have inflammation in the area where the gamma rays enter. And of course, we need to be careful with this skin, using, clothing that is soft, like cotton, no rubbing, not using harsh soaps, or using ointments and lotions that are not prescribed. And avoid, of course, the sunlight. This is the care of this dermatitis. But some patients have a different type of radiotherapy called brachytherapy or implant. In those cases, and it's mainly used in cervical cancer, the patient, the woman, will be hospitalized for 2 days, 2 to 3 days, hospitalized. And then she must stay on bed, comfortably on bed. She can move on bed, but cannot get out of bed. And the doctor will introduce inside the vagina with an applicator that will keep the stuff there, a device that is radioactive device. Is a substance that emits gamma rays and will be there for 2 to 3 days, no more than 3 days. So the patient will be hospitalized for more than 3 days. While the patient must be hospitalized alone in a room, a regular room. But the patient during the hospitalization can stay on bed, cannot get up, because if she gets up, the stuff comes out. You don't want this stuff coming out. So probably is going to be given any kind of care on bed, okay? And this patient, while having this device in the vagina, is radioactive. So this kind of implant, this kind of patient cannot be cared by a pregnant, nurse. And it's a big difference. The nurse that is caring for this client, the same as the CNA, the housekeeper, etc., should limit the time that is inside this room. This time should be limited from 30 to 60 minutes per shift. So no more than this time inside the room. So if you enter to give a tablet and you expend 5 minutes, you count these 5 minutes. Then if you enter to give an injection and it's 10 minutes, then you count this 10 minutes. You are adding with a chronometer the time that you have been inside the room. And when you reach 30 to 60 minutes, then another nurse will take care of this client. You don't enter more to this room in your shift. Maximum time, 30 to 60 minutes. That's why you will prepare all the medication, all the stuff outside, so you only enter, give, and leave. Entering in this room requires to be wearing an apron, a lead apron, lead apron, which is a metal that can block the gamma ray and protect your body. Should include a collar. And also a part of that, you need to be wearing all time something called dose meter that meters or measures the dose, the total dose of radiation that you are receiving in your shift. Is the nurse, the CNA, everybody that enters the room should be wearing a dose meter, okay? An individual dosimeter, that is a badge that you need to wear when you enter the room and count how much radiation you have been receiving. If by accident this device is dislodged and come out, the ideal situation is to have tongs, long tongs, because you should not take that with your hand. Don't touch that with your hands, even if you have gloves. No, don't touch that. Remove that with the tongs. And you should have in the room a lead container where you can put this device inside, okay? And then you call the radioactive environmental service, whatever, to remove that from the room and report to the doctor if accidentally it is dislodged. If there is a question in which you didn't have available neither the tongs nor the lead container, and you find the device on the floor, take your lead apron and throw your lead apron over the device and leave that on the floor and call the environmental services to remove this device, because it is enough to stop the emission of radiation. This is the most important to remember of these brachytherapy, Okay, do you remember cisplatin? Cisplatin, ototoxicity, nephrotoxicity? Look at this question. The nurse cares for a client receiving cisplatin. It is most important for the nurse to follow up on which statement. I drink 8 to 10 glasses of water per day. I now use a soft toothbrush. I take lorazepam after I started cisplatin. My family thinks that I ignore them when they are talking to me. Exactly. So this is the way that Nclex presents ototoxicity. They don't present exactly. they don't present the patient, say, nurse, I have ototoxicity. Say, nurse, my family say that I don't pay attention to them. So you need to connect and suspect that a patient is developing ototoxicity. Remember that you can have the same question in patients receiving aminoglycosides like gentamicin or vancomycin, or patient receiving furosemide. The nurse is administering a vesicant intravenous chemotherapeutic agent to a client, which assessment should alert the nurse to take immediate action. Complaint of pain in the site of infusion, rash in the client's extremities, stomatitis lesion in the mouth, severe nausea and vomiting. What is the priority if you have a patient receiving IV chemotherapy of these 4 complaints?
B.
Yeah, I would say B, the rash.
A.
Remember this, guys. If you are the nurse responsible of receiving chemotherapy in patient, and the catheter that should be inside the vein dislodges, which is very common, okay? The vein get broken, the catheter is displaced, okay, is moved, etc. And then now the catheter is not anymore in the vein. Trying to imagine a catheter, trying to have this visualization, a catheter that is, ¿dónde está mi? I don't see my stuff. A catheter that is outside the vein, and the liquid, okay, ya apareció. The catheter is outside the vein. No, this is the vein, and the catheter is here. This is the skin of the client. Yes. Yeah, is out, and then you have this substance spilling here. And this substance is a substance designed to kill cells. What do you think is going to experience a person that is having this spillage of a substance that kills cells? You see how it kills the cell? What is going to experience? Pain.
Pain.
Yeah, pain is logical. So the question is exploring if one day you start working as a nurse because you pass the Nclex and they assign you to pass an IV chemotherapy to a patient, if you are very aware that any pain, discomfort, swelling, etc., should immediately require your intervention, because if it is not done properly, this is the consequence. Okay, if you have the responsibility in this patient of supervising the IV administration of the chemo, the patient has an extravasation, and the patient ends with this lesion, do you think that you will be in problem? Yes. And obviously, it is important. Okay, it is important. The intervention in this case is stop the infusion as soon as possible. Don't remove the catheter. Leave the catheter. Take a syringe and trying to suck back most of this liquid. Okay, most of this liquid and the blood that you can remove, and leave the catheter. Talk to the doctor, because some of these substances have antidote, okay? Have antidote. So this is the priority, okay? It's even a priority before a rash in the extremities, stomatitis, and the nausea and the vomit, because you need immediately to stop the infusion, immediately suck the lesion, okay? While the others requires more assessing, more follow-up, etc., and is less a priority, okay? Okay, guys, this is what I have for you today. I finished what I have prepared for you. Any question?
No, Professor, thank you.
Okay, so see you on Monday there, okay?
Thank you, Professor.
Thank you, Professor. Good night.
Thank you.
Good night.
Thank you, Professor.
Thank you. So, people.
Thank you, Professor.
You. Uploaded.